I'm Dr. Pei Yung Lam. I'm the pediatrician who has the privilege of working at the BC Children's Provincial Specialized Eating Disorder Program. I also want to introduce my fabulous team. They will be coming up individually. So first off, I have Judy Lehrman, our dietitian. Stand up. No, just stand up, Judy. So this is Judy, and we have Karina O'Brien, who's our psychologist. We have Kathy DeCoste, who's our clinical resource nurse. I hope I got that title right. So our clinical resource nurse. And Karen Dixon, who's our social worker / family therapist on the inpatient unit, and sometimes a little on the outpatient. And last but not least, Tom Boslaw, our family educator. So this is my fantastic team that I have the privilege of working with every single day. Thanks, guys. So I realize that we are on a tight timeline, so I'm going to move forward very rapidly. And these guys will be up here intermittently during my talk to tell you a little bit more about their roles. But I just want to preface everything by saying that I realize, and it's been said a few times already by various people, that I realize that this isn't Vancouver. I realize that you don't have my team. And I realize how lucky I am because I was in your shoes before, in my previous occupation, in my previous place of work. And I did not have a team like this. And I realize how hard it is as a solo practitioner in your clinic, Annalise, sitting there thinking, what the heck am I going to do? Who am I going to call? And I have to manage this kid all by myself. So I have been there, and I totally understand how you guys feel. So hopefully what we will present today will help a little bit to move things forward. So as I said, we have a tight timeline, so I'm going to move forward quickly. So a quick introduction about eating disorders. This is how I envisage an eating disorder. I see eating disorders as a little bit of a spectrum, where on the one hand, you have normal, natural eating, and then some people, where you eat when you're hungry, and you stop when you're full, and most of the time, you're okay with your body. And then there are people who diet all the time, and you know them. We've all got these friends. They count calories, they might skip meals, they think they follow the latest fad diet, but it just doesn't stick, and they're always on and off and on and off. But to me, where it crosses the line is when these people stop sort of being, they have periods where they're off their diet and they don't think about it. Where they cross the line is when they start thinking about it all the time. It obsesses their thinking, it's preoccupying their thoughts, and that's all they talk about. And that's when something is wrong. And then we move into the sort of full-on clinical eating disorder. I know this isn't DSM-5, but this is how I conceptualize the progression of the illness. Eating disorders are a disease, the mental health illness, which has the highest mortality rate. And the major cause of mortality in eating disorders in adolescents are, number 1, suicide, number 2, suicide, and number 3, suicide. And people don't talk about that enough. And I think that suicide really does deserve to be really thought of and considered when you're assessing a new person that you're seeing in your clinic. The next thing that is causing death is really cardiac arrhythmia and circulatory failure. And that happens as a result of various electrolyte imbalances, and I'm going to go through that fairly quickly. And the third thing that happens more, I think, in adults than in adolescents and teens is when they start using substances and when they get into substance abuse. All of these are preventable with early diagnosis and treatment. So this is some quick statistics that are out recently from the province of BC. The Macquarie Foundation publishes stats on all sorts of adolescent risk-taking behaviors every sort of 3 or 4 years. The 2013 BC Adolescent Health Survey shows that there's a trend for males to be underweight, as you can see here, increasing in underweight males. The amount of underweight females is fairly static, but as per usual, about half of healthy weight females were trying to lose weight. About 5 or 10% of females are vomiting on purpose after eating. And these are grade 9, grade 10 kids. A third of healthy weight males were trying to gain weight. Now, I don't know if that means anything to you guys, but really to me, that says that this is an eating disorder where the males are trying to achieve the six-pack, and they're using the protein powders, and they're going to the gym, and they're buffing up. And this, I believe, is the new form of eating disorders in males. But you do also have 13% of healthy weight males trying to lose weight. So the CPSU, or the Canadian Pediatric Surveillance Unit, published by Leora Pinhas in 2011, showed that 5 to 12-year-olds there was 2.6 cases per 100,000 person years. So it's happening in kids under 12. And certainly our unit right now, we have quite a cluster of 13 and under in our unit. The highest incidence currently seems to be in the 10 to 12-year-old age group, in that age group, and predominantly female, but we are seeing quite a few males as well. And these, when you are 10 and you have an eating disorder, growth and pubertal delay become paramount. And I will talk more about that as well. Oops. So I'm going to move forward to the shared philosophy of care. And this was the phrase at the top, comfort the afflicted and afflict the comfortable, I thought initially was a little trite, but really it is kind of what we do, because we want to be there to comfort those who are feeling down, to support those who are feeling down, but we also want to afflict the comfortable eating disorder. The eating disorder that's kind of settled in and made themselves right at home in your family home or in the clinic, we want to shake that thing and we want to make it uncomfortable. So that's kind of embodies what we want to do. Riley and Terry have already said a lot of the points that we're putting up there. The adolescent is ill, is out of control. They are not able to make correct decisions about eating, about activity, about any of that sort of, anything to do in those two areas. We see the family as the resource who supports that kid. And we all have to work as a team, especially including the parents. You cannot exclude parents from this process. And Riley and Terry again have said that recovery is a process. You know, Annalise, you and I know we can achieve nutritional recovery, right? That is easier to do, even though it's not easy at the time, it's easier to do than the emotional recovery. But it is a process. You have to have that first before the emotional stuff can happen. And I'll explain why. Strong communication is highly, highly important amongst all members of the team, and we do also have a trauma-informed approach. So I'm going to invite Karen and Tom and Karina to come up and talk a little bit more about our philosophy.
All of us work with youth and work with families in our program, but the three of us in particular work primarily with families. So we want to really make the point of how important it is to involve the families in treatment. And we were each going to say a little bit.
We believe that the main people to help people recover are the family, and in particular the parents. Parents have always been managing their children's care from birth onwards, and we do not see that changing when there's an eating disorder, and just really want to make the point that professionals that are involved really need to honor that.
When parents come into the program, I meet with them early, and one of the things that I always try and point out is that most of the work that's going to be done is at home. Even when there's hospitalization, hospitalization is for months, maybe, but recovery may be for years. So parents really do most of the groundwork.
I just wanted to share a great quote from Dr. Yvonne Eisler, who is a psychologist at the Maudsley Hospital in London and one of the founding fathers of the treatment approach that I'm going to talk about in a little bit more depth later today. What he says is, as a clinician, what I'm struck with time and time again is the similarity of the processes through which the family becomes organized around the problem. The problem, of course, being the anorexia. And he calls this the central organizing principle. And in my work with families, I sort of think of this as the eating disorder kind of becoming like the sun in the solar system, and the whole family starts to orbit around the illness and accommodate the illness in their family. And one of the roles of us in tackling the eating disorder is to figure out in what ways the family is changing their behavior to accommodate the eating disorder and begin to interrupt that process.
Sometimes you see families doing kind of odd things and you think maybe that was involved in the eating disorder, but we think it's probably the other way around.
Right, that wasn't the cause of the eating disorder, but rather the eating disorder caused this behavior.
I believe it was either Karen or Karina who made me put this slide up here, basically in bold type. I should have had it in red, but kids need to eat, and food is the medicine that we use to treat eating disorders. That's the other philosophy that we have. So I want to go back to this communication, which you guys raised, because I honestly think that with our team communicating, even though we all work down the same hallway, on the same floor, we still have to focus on our communication time and again. And it is so much harder when you are scattered here, there, and everywhere, and you're not in the same building. And I know it's really important because even with us being right next to each other, there's always some kind of loophole that the eating disorder finds, because it's really, really tricky. And I could give you tons of examples about loopholes. And the best one would be, Dr. So-and-so says I'm okay to go and exercise now. So Mom, you can't say anything. And so this has to be clearly communicated time and again within the team members, within the treating team, that this wasn't what happened at the visit, et cetera, et cetera. And I think that the medical and the mental health components are equally important. All of these communications about what happens in therapy, what happens in the doctor's clinic, that has to be made transparent. And it has to be regular. And so my challenge to you is to, if you are not in the same room, if you're not even in the same building, or even, within 10 kilometers of each other, which I guess is probably the situation here, is that we need to experiment with different methods of communication. And we need to really keep and stick to those different methods of communication. For example, setting up an email group, setting up regular times to meet, making sure that we have on the agenda when we meet what we're going to talk about with this person, and be clear that when you're discussing, okay, I'm seeing such and such on Thursday, this is what I'm going to say, what are you going to do when you see them for therapy on Wednesday, and how are you going to set that up for me, or how am I going to set my meeting up for you? And I think that communication is absolutely crucial. So moving on from that, I'm going to talk a little bit about our team roles, and as I said, my fabulous team is here, and I'm so privileged to have this. But for those of you who don't have the team, who are working out in the community by yourselves, I have had to learn myself how to do a little bit of each of these roles too. And you need to really take a little bit from there, because at various points you will have to be the dietitian, you will have to be the psychologist or the therapist, you will have to do some family work, and you will have to do lots and lots of family education. And I find that we have to all be flexible and be able to combine all of this. And for the therapists out there, yes, you will have to talk about medical things because it'll help you in your therapy. So I'm just going to move forward. So I feel like the role of the pediatrician or the family physician really is that they are the gateway. The kid and the parent will come to you first because something bad has happened to make them come to you. And your role, or my role, is to look at medical stability, to be monitoring for complications in the short and the long term, so don't forget the longer term. And sometimes, in a lot of cases in the community, the family physician or the pediatrician often has to be the case manager or the person that's keeping it all together, because they might be the only one that the kid is okay with seeing, that the family is okay with seeing, for all sorts of reasons. And if you don't have ready access to a psychiatrist, you do have to be the one that's prescribing the medication. So I feel that those are the roles that a doctor in this setting would have to play. And yes, you do have to know a little bit about meal plans and so on, but that really is Judy's role.
Hi, I'm Judy, dietitian. So if I were to sum up what I do in 3 points, so basically I see my role as being both medical and therapeutic. One is to help achieve a healthy body weight, and we do that whether that's via a meal plan, appropriate increases, normalized eating behaviors. In the inpatient unit, we automatically have food rules, so there's certain things that they're somewhat forced to have that they would avoid, through working on challenge foods, and just by having that regular structured eating. And the last part of my job is I provide nutritional education both to parents and also to the patients. The framework that I use, this is a framework that I use when I look at nutrition in the eating disorder population. So the first thing that I worry about when I'm looking at a patient with an eating disorder is adequacy. Is the child getting enough that they're not losing any weight? I don't really care what they're eating. It can be, 6 ensures, it can be 1,000 carrots, it can be 10 cookies. I don't care. Are they eating enough that they're not losing any weight? The next level that I focus on is what I call balance. So are they eating within the food groups? I don't care if there's any variety, fruits and vegetables, just be an apple. I'm happy. The next section is what I call variety. So again, within the 4 fruit groups, we have some variety. So it's not just apples, it's pears, bananas, broccoli, a lot of different things. The next section is what I call the challenge section. And that is, there are some very typical challenge foods in the eating disorder population, but they vary. They do vary from individual to individual. It could be as having a dessert, eating in a restaurant. But again, they can be quite specific to that patient. And I think it's important for us not to assume that we know what's challenging for these patients since they are different. The last section is what I call the health section. This is the section which I find patients, families, healthcare professionals, and I'm including dietitians in this, that we tend to focus too much on. Those are the messages that are out there in society around what type of fat should I have, whole grains, how much salt, all that, all that stuff that's out there. And what I find is that, particularly in this patient population, is they focus so much on that health stuff, they forget everything below, and they become very, very restrictive. So I think it's really important that I think we all in this room have our ideas around what's good, what's bad when it comes to food. And I think it's really important that we're mindful and we recognize our boundaries when we talk about food with this patient population. This framework is a lot different than canine one, but there we go. All right, I'm going to pass it on to the fabulous Kathy DeCoste.
I'm the clinical research nurse on the inpatient unit. My role is I'm out on the floor most of the time. I'm coaching, mentoring, supporting, and lucky enough to just hang out, AKA building therapeutic alliances with the patients, the staff, and the families. I'll go more now into that nursing role. Okay. Keep that. No, go back. Okay, yeah, that's great. Okay, that was all the appetizer. Now we're going to serve up the main course, focusing on therapeutic alliance. Why is therapeutic alliance important? Did anyone think of trust, caring, rapport building engagement? How do you accomplish this? By being patient, mindful, empathetic, consistent, approachable, calm, engaged, curious. And I know that sounds like a tall order, but all that helps. And some examples are, what book are you reading? Did you get to see your dog while you were home this weekend? Playing games with them, knitting, guitar playing, and singing along with them, learning about their hobbies and interests, and also bringing new interests to help them build strengths. We do this daily on the unit. We teach them how to play the ukulele. We give them guitar lessons. We teach them how to play the piano. Knitting, we do a lot of knitting. Crossword puzzles, they never would imagine they'd be doing those, but we have them doing those and they enjoy them. And when you demonstrate caring through encouragement, listening, being curious about their lives, this builds that critical trust, and they know you are there for them. This allows them the freedom to be vulnerable and feel safe. So you use this during meal support, post-meal. We have daily check-ins with them as well. Consistency. Having consistency helps with therapeutic alliance. What does this mean on the inpatient unit where we are? Well, we have a schedule, and it's Monday through Friday from 8:30 till 6 o'clock every day. It's consistent and predictable. Meals and snacks are all at the same time. Meal support staff are present for every meal. Pre and post staff are assigned for every meal and snack. Every patient is assigned a primary worker, a nurse, or a youth and family counselor as their identified support for that day. Patients are aware that 100% completion is expected of them. Their schedules and activities of daily living are predictable, and there are no surprises. We have visual boards to show patients who they are working with and who is on the interdisciplinary team. The model that guides us is the trauma-informed practice, and there's 4 principles of, we call it TIP. Trauma awareness is we are committed to providing care from a trauma-informed approach, which begins with building awareness among staff and clients of the commonness of experiences of trauma. Safety and trustworthiness is the second one. An example of that is our daily check-ins with our patients. The third, opportunity for choice, collaboration, and connection. An example of that is we have community meetings twice a week where we meet with the staff, with the patients, and any staff that are available, and we discuss any safety concerns, physical, emotional, within the group, any group dynamics that are happening, and solve as a community. Strength-based skill building, some of our groups, mindfulness, connection group, DBT. Team support. Team support when providing meal support. An overview of meal support is discussed in what we have daily management meetings in the back room, and these are done at 10 o'clock after breakfast and snack, and just after we get a feel of how the unit is running. Consistency of care, and we discuss that this daily management is a milieu of the unit, and included in that is meal support. So consistency of care means all the staff are consistent when doing meal support for each patient. When a patient wants to switch a food item more than 3 times, this indicates a pattern. Spilling, cutting into small pieces, any other eating disorder behaviors, all staff are made aware of at this time, and support is given to help with these behavioral problems. Completion is very important, and if an individual is struggling, this is also discussed in our daily management meetings to collaborate and strategize about individual plans. Being consistent prevents splitting. Building competency for staff. To build competency, there's a formal and informal learning opportunities. Informal learning happens at the daily management, where if a staff has a challenging patient care situation, they share this experience with their colleagues at this daily meeting, and then staff feel empowered, and this informs the future care of the patient. Highlighting behavioral issues. We created a visual to refer to over the course of the day. And in this example, shown the butterfly symbolized the patients, and the sticky symbolized the behaviors the patients need support with. Our work can be very stressful and intense. So to meet our ultimate goal of happy patient, happy staff, happy patient, some strategies we use on our unit are reflective team practice, asking the question what worked, what didn't work, encouraging positive feedback, these daily management meetings, and starting next week, all staff are attending compassion fatigue workshops. Team support for staff impacts patient care. Again, we use this at daily management. We have a milieu meter, which is shown here, and this is a visual tool to measure our safety and the mood in our environment, which is shown. The staff find this helpful for building consistency and containment. Again, we meet at 10 or 11 o'clock to assess and determine the milieu, which includes safety, high cooperation, engagement, and meal support. We ask staff, are you feeling safe? You think the patients are feeling safe? The yellow means it's yes. No, I'm sorry. Green means it's yes. Yellow means it's unease. And red means not feeling safe. This helps us stay one step ahead of changes in mood status. It also supports the casuals, the shift workers in general, to be prepared when they came on. They can have a look at this meter and also the meal support one that I showed you. From my many years of experience, I have learned that you must value the person before the illness through building caring alliances, being curious, and showing respect. What I really hope you walk away with from today, remember at the beginning I said, with the main cause. Well, the 3 main ingredients would be of the nurse's role is caring and compassion, consistency, and competency.
Hi, I'm Karina, and I'm actually one of 3 psychologists that work in our program. And I just wanted to mention briefly, sometimes when people think about the BC Children's Hospital program, they think about the inpatient program, but we actually have 2 other components to our program, a day program and an outpatient program. And I primarily work in the, sorry, all of us have laryngitis today. I primarily work in the outpatient component of the program, but of the 3 psychologists, we're all spread pretty evenly throughout the 3 components. And one of us is full-time and the other two are part-time. I'm one of the part-time people. So we're involved in the assessment process, and we work interchangeably with psychiatry in the assessment in tandem with a pediatrician to provide the initial intake assessment that determines where a person travels, either within our program or back into the community. We're involved in intervention, and I often provide family-based interventions, but we're also involved in specific interventions for comorbid conditions at times, such as OCD or social phobia, or at times we'll provide other types of treatment that go beyond a family-based approach, like an individual therapy, a group therapy approach. We're involved in consultation services to the community. And I'll just let you know that myself and another psychologist do offer a monthly consultation service for folks in the community that's a phone-in around doing family-based therapy. So after I talk about that later today, please let me know if you're interested in being involved in that, and I can give you more information about that. We're involved in the supervision of residents and in both psychology and in medicine. And one of us in particular, the full-time psychologist, is quite heavily involved in research, both outcome research in terms of our program specifically, and in doing original and collaborative research with other services. So that's the very broad overview of the kind of things that we do. I know you don't have psychologists currently in your region, but that doesn't mean that you don't have all of these things that need to be done. So kind of thinking about which professions might fill each of these roles in your service. Thanks.
Hi there. So I'm Karen, and I'm one of 4 social workers in our various programs. There are 2 on the inpatient side, 1 in the day treatment program, and 1 half-time outpatient social worker. Our role is doing family therapy, both family-based therapy, as Karina mentioned, on the outpatient side, and traditional family therapy on the inpatient unit. The rationale for our involvement is that the eating disorder occurred in the context of the family, and so too will the recovery. Eating disorders both impact and are impacted by family relationships and roles, boundaries, and so forth. The extent to which the family is positively engaged in the recovery process will have a profound impact on prognosis. As you've likely picked up on by now, children and youth come to us scared, often extremely medically unwell, confused and unable to help themselves get better. Their parents arrive to us terrified that their child might die, often exhausted and hopeless after weeks or months of trying to help their child eat. They may be angry with their child, with their spouses, or themselves. There might be resentment, guilt, shame, and accommodation to the eating disorder out of sheer desperation. Their livelihoods and outside relationships may have been affected. Siblings arrive scared, angry, and at times feeling legitimately like their needs have been neglected. So I see my role as involving the development of a caring relationship with family members so that they feel safe. I conduct an assessment of family structure and functioning that includes parenting styles, coping under stress, communication, beliefs, etc. I try to offer hope, increasing knowledge of and competence with the tasks and obligations of eating disorder recovery. I actively work with family roles and structures so that children feel safe, supported, and contained in their families at the same time as their parents feel able to fulfill their roles effectively. My intention is also to work towards opening up areas within the family that may inhibit recovery. These areas might include, but are not restricted to, how parents manage when they're stressed, how consistent parenting practices are between parents, how parents and family members manage conflict, how family members understand the illness and other beliefs, how emotions are regulated, and how parents support the co-regulation of their children, and how siblings are managing. I think I'll stop there. I have a lot more to say, but I'll let Tom finish with his role.
I work with parents, and 2 questions that almost all parents ask when they come in is, sure, kids will eat here for you, but what happens when they go home? And the other question that they ask is, how do you get them to eat? What happens if they refuse? What should we do? So that's my job, is to try and answer those questions. And I think that's the job of everyone here, is we can do our part in the hospital, but it's really what happens at home that's what counts. So when kids come into the program, they get therapy and treatment. So we want to provide parents the same kind of treatment and education. When they come into our program, I do a formal workshop with them that's about meal support and eating disorders. Karen and I run a parent support group that we do each week, which gives a different kind of education. I can't remember if you were in at that time. So the parents can talk to other parents and get an idea of what actually happens when people go home. I will say we work in this building, that building, and we don't really know what happens when people go home. But other parents have done that, and they know what happens when they go home. So you should probably talk to those parents, and they might give you some ideas. We also do hands-on training for meal support. We get parents involved in doing meals as quickly as we can, and that's part of my job, is to help teach them and get them through that process, so that the final week in hospital is very similar to the first week at home. The parents are doing most of the meal support, and then they're doing all of the meal support. So I'll be talking a little bit about meal support later on in the afternoon.
As I said, I do have a fantastic team, and certainly one that was light years away from what I had when I was working out in my clinic all alone.